right, reproductive physiology. So when we talk about the reproductive system, we start by talking about gametes. And the gametes are the haploid cells, the sperm, and the egg. So going back to like general E&P, when we talk about the cell cycle, we talked about cell division being mitosis. And in mitosis, if you remember the cell cycle, mitosis had the 4 stages: prophase, metaphase, anaphase, telophase. And then following mitosis was cytokinesis, where a cell would then split in half. Now, before a cell goes forward with splitting in half, first we would have to replicate all the genetic material inside of the cell. So once we do this replication process, all of the genetic material would be copied and then duplicated, so that when the cell grow really large and split in half, each resulting cell would have the same copies of all of the genetic material inside of them. So when we get to that point, that's basically mitosis. Now, when we talk about meiosis, meiosis is when you basically go through the process of mitosis twice. So you would still do the duplication of the chromosomes up front, but you divide once to get back down to that diploid number where you have 2 copies in each cell, and then you would divide an entirely second time. So what you end up at the end of meiosis is 4 cells. Each one has 1 copy of each chromosome. And that's what we need, because then we take the sperm, which has 1 copy of each chromosome, and unite it with the egg, which has 1 copy of each chromosome, and we combine it together to make a diploid organism. The process of meiosis is covered in a separate supplemental video, so go ahead and take a look at that supplemental video, but we're going to continue on by talking about spermatogenesis, oogenesis, and how the sperm and egg come together to create embryo, and how that embryo implants and goes on and through development, and a little bit of inheritance in here. So starting off with spermatogenesis. Spermatogenesis is sperm production. When you see the word genesis at the end of the word, it's the creation of something. It's making something. So spermatogenesis, it's making sperm. The hypothalamus releases GnRH, gonadotropin releasing hormone. FSH and LH are then released from the anterior pituitary gland. Spermatogenesis is stimulated by follicle stimulating hormone, and luteinizing hormone, or LH, causes the release of testosterone, which further promotes spermatogenesis. It begins at puberty and continues throughout the lifetime, diminishing in old age. So this shows how sperm are created. So you have these cells which eventually continue to divide, and eventually you get down to the individual haploid cells, which then will be released. And they kind of stay inside of the epididymis, which stores sperm, until it is released from the testes. Oogenesis, or the creation of the egg, and the sexual cycle happens in the female. So reproductive cycle, it's a sequence of events from fertilization to giving birth and returning to fertility. The sexual cycle are the events that occur every month when no pregnancy occurs. The sexual cycle consists of 2 interrelated cycles controlled by shifting patterns of hormone secretion. The ovarian cycle, which are the events in the ovaries, and the menstrual cycle, which are parallel changes in the uterus. So oogenesis, egg production, produces haploid gametes, haploid meaning that they only have 1 copy of each chromosome, by means of meiosis. It's a cyclical event that normally releases 1 egg each month. It's accompanied by cyclic changes in hormone secretion, histological structure of the ovaries and uterus, and uterine changes resulting in the monthly menstrual flow. Female germ cells arise from the yolk sac during embryonic development. So while a baby female is growing in utero, she's already developing her eggs. They colonize the gonadal ridges for the first 5 to 6 weeks of development. They differentiate into oogonia and multiply until the 5th month. 6 to 7 million in number, and they arrest their development until shortly after birth. So while the baby's developing, she's already developing her own eggs. Shortly after birth, oogonia transform into primary oocytes, and they go as far as early meiosis 1. So when we talk about the stages of meiosis, hopefully you had a chance to review that supplementary video already, but we go through prophase 1, metaphase 1, anaphase 1, telophase 1, followed by prophase 2, metaphase 2, anaphase 2, telophase 2. So these pre-eggs, called primary oocytes, stop their division cycle as early as meiosis 1. Most undergo degeneration or atresia by the time the girl is born. So by the time the girl comes into the world, they have mostly degenerated. Follicles undergoing atresia are called atretic follicles. The egg or ovum at any stage from the primary oocyte to the time of fertilization. During early childhood, 90% of follicles undergo atresia. By puberty, only about 200,000 oocytes remain, but that's more than enough for an ovulation each month from age about 14 to about 50. Egg development resumes in adolescence. FSH stimulates monthly cohorts of 20 to 25 oocytes to continue development. Meiosis 1 is completed on the day of ovulation. So when ovulation happens, an ovulation is releasing of an egg from the ovary. We've gone through meiosis 1. It produces 2 daughter cells, a large one, which is called a secondary oocyte, and a much smaller one, the first polar body. The polar body and its daughter cells degenerate, a way to discard extra set of chromosomes and leave cellular material to the secondary oocyte. Secondary oocyte has much cytoplasm as possible because if it's fertilized, it has to have enough material to divide repeatedly to produce numerous cells. The secondary oocyte proceeds as far as metaphase 2, but it arrests until after ovulation. If not fertilized, it dies and it never finishes meiosis. If it's fertilized, it completes meiosis 2 and casts off a second polar body. Chromosomes of the egg unite with those of the sperm. And this is just a diagram of the development of the egg and the development of the follicle. And here's another diagram that we can kind of go through. So a primary oocyte is typically inside of a primary follicle. And then we have a secondary oocyte. So primary oocyte is 2N, it's split, now we have N, and then we have this polar body that's kind of released and that dies and goes away. And then inside of the secondary follicle, we typically would have that secondary oocyte. And then secondary oocyte, if it's not fertilized, it dies. If it is fertilized, it's going to continue on and finish up meiosis 2, producing another polar body or giving off another polar body, and then eventually gets fertilized and will combine with the sperm to then double the chromosome number. If we look at what's happening with the follicle, the primary follicle has the primary oocyte, and then it develops further to have the secondary oocyte, and then you develop into a tertiary follicle, which is ready to release this pre-egg. And then once you have ovulation happen, so ovulation is the releasing of the egg, it will burst open, releasing the egg, and at that time we're through meiosis 1, starting meiosis 2, and if it's fertilized, only if it's fertilized will it complete meiosis 2. And here's another diagram that you can review. So folliculogenesis, genesis is the creation of something, folliculo is referring to the follicle. So it's important to distinguish the follicle from the egg. The follicle is just the case inside of the ovary that holds the egg, while the egg is the ovum or oocyte that we've been talking about. So the follicle develops around the egg. And the development of the follicle that occurs as the egg undergoes oogenesis. It's important to note what's going on with the follicle because eventually the follicle is going to start to produce some hormones that are going to dictate what can happen with that egg. So, starting off with the primordial follicles. Primordial follicles, the primary oocyte in early meiosis, is surrounded by a single layer of squamous follicular cells. They're concentrated in the cortex of the ovary. They form during fetal development, but then must wait 13 to as long as 50 years before developing further. So why? Well, during fetal development, so while a baby girl is developing in utero, she's already developing her own eggs. Now, after she's born, it takes about 13 years before she's going to have her first menstrual cycle. And she's not going to release an egg from her ovary until she reaches her first menstrual cycle. So since that doesn't happen until about 13 years of age, that's why we say they must wait 13 years. So why would it wait as long as 50 years? Well, you're only going to release an egg once a month every time you ovulate. So these follicles are only going to develop along with the cycle that will eventually lead to the release of an egg. So if our first cycle happens when we're about 13 and our last cycle happens when we're about 50, we are going to release eggs and develop these follicles with the eggs once every month until age 50. So if you are an individual follicle and we're following the life of one individual follicle, that individual follicle may go that entire person's life without ever developing further because it wasn't stimulated to. Other follicles were stimulated to develop instead. The adult ovary has 90 to 95% primordial follicles. Monthly recruitment, or primordial follicle activation, of 20 to 25 follicles begins 290 days past maturity. Only one will finish, and the rest die. Primary follicles are recruited. Primordial follicles become primary follicles, contain larger secondary oocytes and a surrounding layer of cuboidal follicular cells. Secondary follicles, the oocytes are even larger, and the follicle cells are now in 2 or more layers. These are now called granulosa cells. The zona pellucida is a layer of glycoprotein gel that's secreted by the granulosa cells around the oocyte. Tertiary follicles appear about 60 days before ovulation, when granulosa cells begin secreting follicular fluid into small pods. Mature follicles, about 20 days before ovulation, one follicle becomes dominant, the one destined to ovulate. The dominant follicle captures and accumulates follicle-stimulating hormone, while the other follicles do not, and their development slows down. At about 5 days before ovulation, it's large enough to be considered a pre-ovulatory or Graafian follicle. A pre-ovulatory follicle reaches a size of about 30 millimeters by the time of ovulation. It's almost as wide as the ovary is long. As ovulation approaches, cumulus oophoros detaches from the oocyte. Oocyte floats freely in the antrum. So sexual cycle, rhythmic changes in the ovaries and uterus that correlate with the oogenesis and folliculogenesis. Average is 28 days, but varies from 20 to 45 days. The basic hierarchy of hormonal control, the hypothalamo-pituitary-ovarian axis. The hypothalamus tells the pituitary to secrete hormones, which tells the ovaries to secrete hormones, which tells the uterus to do its thing. The hormones of the hypothalamus regulate the pituitary gland. Pituitary hormones regulate the ovaries. Ovaries secrete hormones that regulate the uterus. Ovaries exert feedback over control over the hypothalamus and pituitary. The cycle begins with the 2-week follicular phase. Menstruation occurs during the first 3 to 5 days of the cycle. Uterus replaces lost tissue by mitosis, and cohort of follicles grow. Ovulation around day 14, the remainder of that follicle becomes the corpus luteum. The next 2 weeks, the luteal phase. The corpus luteum stimulates endometrial secretion and thickening. If pregnancy does not occur, the endometrium breaks down in the last 2 days. Menstruation begins and the cycle starts over. So this is a really good diagram that I love because instead of just reading a bunch of steps, now you can see what's actually going on. So you have this primary follicle which is going to be stimulated to develop into a secondary follicle. Now, follicle stimulating hormone is initially released to stimulate all of these follicles to start to mature or develop further. So about 20 to 25 of these are stimulated, but one of them is going to start sequestering the follicle stimulating hormone. So we decrease follicle stimulating hormone secretion, and one of these is really going to start absorbing it from the environment and self-perpetuating this growth. It's going to develop further into the tertiary follicle, and eventually you're going to have this surge of luteinizing hormone known as the LH surge. And when this surges, it's going to cause ovulation. So ovulation, it's going to release the egg from the follicle. So now you have an empty follicle, and that empty follicle is going to bleed slightly, but not enough to be noticeable. So that whole phase is the follicular phase. It's growing and maturing of the follicle leading up to ovulation. Then you get into the luteal phase. An empty follicle turns into what's known as the corpus luteum. It becomes hard, and there's some scar tissue that forms around it, but it also starts producing a hormone, and that hormone is progesterone. So during the luteal phase, progesterone is going to start to be produced. Now at day 14, when you have the ovulation event happen, this is when the individual is most fertile. Typically, you want to already have sperm inside of the vagina before the date of ovulation. I've heard a lot of people in the past trying to get pregnant, and they try to figure out body temperature and do these ovulation test kits, and they do all this math and calculations, and they try to only have intercourse on the day that they ovulate. And then when they never get pregnant, they're like, what's going on? You actually have to already have sperm inside several days before ovulation occurs. And it is possible that even with all those advanced tests that are available, you miss the time of ovulation and the egg is lost. Or it happens too late and the egg meets the sperm too late. And even though maybe they unite and maybe there's a fertilization event, it happens to get passed out because it was a little too late. If sperm is already in the vagina, that means that the sperm cells are further developing, and they can actually be stored in the corners of the vagina called the fornix, and they can then be ready for that fertilization event. They can already be beginning their journey up into the uterus at that time. Now, we talked about previously that what happens is we start to accumulate during the luteal phase endometrial secretion and thickening. That thickening could block the entrance of the sperm into the cervix, which could further prevent a pregnancy event from happening. So definitely want to have sperm in the vagina prior to ovulation so that an ovulation event can be as successful as possible. But once we have the corpus luteum produced, this is now going to produce progesterone. Progesterone's job is to maintain the uterine lining. So it keeps the uterine lining in place, and it's going to continue to produce and develop and further develop that uterine lining. If there is a fertilization event that happens, the corpus luteum will continue to produce progesterone on its own for a couple weeks. After that, once you have the implantation event happen, that developing embryo is going to start producing HCG, or human chorionic gonadotropin. And HCG is the hormone that's detected by the at-home pregnancy tests. And blood levels of HCG can be detected by clinical tests and all sorts of stuff. So HCG is our primary pregnancy hormone. What HCG will do is it tells the corpus luteum, keep producing progesterone. Keep our uterine lining intact. And that allows for that implantation event to be fully successful. Now, if there's no fertilization event, the sperm doesn't enter the egg, then there's not going to be HCG produced. So eventually, this corpus luteum is going to go through the process of involution, where it stops producing progesterone and At that time, there's nothing telling the uterine lining to stay in place. So at this time, we're going to have shedding of the uterine lining. And then for the first 7 or so days of the cycle, we're going to have menstruation occur. And then after menstruation, you've got a short window where ovulation will occur, and it goes on from there. So the follicular phase extends from the beginning of the menstruation until ovulation, day 1 to 14. Most variable part of the cycle, seldom possible to predict the date of ovulation. This is again why it's important to just have regular intercourse if you're trying to get pregnant almost daily before an ovulation event would occur. As I mentioned, FSH stimulates the follicles to grow and secrete estradiol. Dominant follicle has the richest blood supply and the greatest density of FSH receptors. Anterior pituitary produces a surge of luteinizing hormone and a lesser spike of FSH, which causes the formation of the secondary oocyte. The follicle swells with fluid, and it bulges from the ovary. A nipple-like stigma appears on the ovary's surface. Immune cells secrete enzymes that weaken the follicular wall, and nearby ovarian tissue and the uterine tubes swell with edema in preparation to catch the egg. So this is that hormonal cycle that I've already discussed. Ovulation, the rupture of the mature follicle and the release of the egg, takes only 2 to 3 minutes. Oocyte and follicular fluid are swept up by ciliary currents of the uterine tubes. Then you have the luteal phase, the post-ovulatory phase, which is from day 15 to day 28 on average, although it can be as long as 45 days. From just after ovulation to the onset of menstruation. If pregnancy does not occur, the events that happen are the follicle ruptures, it collapses and bleeds into the antrum, granulosa and the theca interna cells multiply and fill the antrum. Ovulated follicle becomes the corpus luteum, named for the yellow lipid that accumulates in the theca interna cells, now called the lutein cells. Luteinizing hormone stimulates the corpus luteum to grow and secrete estrogen and progesterone. Estrogen and progesterone prepare the uterus for possible pregnancy, also inhibit luteinizing hormone and follicle-stimulating hormone secretion by the pituitary via negative feedback. Basically, we don't want it to ovulate again if we've already just ovulated. If pregnancy does not occur, the corpus luteum begins involution, or shrinking, around day 22, 8 days post-ovulation. By day 26, involution is complete and scar, corpus albicans, remains. As corpus luteum degenerates, estrogen and progesterone secretion drops. The pituitary no longer is inhibited, and FSH levels begin to rise again, stimulating a new cohort of follicles. The oocyte that ovulates each month was reactivated 290 days earlier, not in the new cycle when it ovulates. New cohorts are activated every 28 days, overlapping and trailing each other, with their dominant follicles ovulating 28 days apart. The menstrual cycle consists of a buildup of endometrium during most of the sexual cycle, followed by its breakdown and vaginal discharge. It runs concurrently with the ovarian cycle, and it's divided into 4 phases: proliferative, secretory, premenstrual, and menstrual. The first day of noticeable vaginal discharge is defined as day 1 of the sexual cycle. Menstrual phase averages 5 days long. The proliferative phase involves the rebuilding of the functional layer of the endometrium that was lost in the last menstruation. At the end of menstruation, day 5, endometrium is a ½ millimeter thick and consists only of the basal layer. As the new cohort of follicle develops, they secrete estrogen. Estrogen then stimulates mitosis in the basal layer and regrowth of blood vessels to regenerate the functional layer. By day 14, the endometrium is 2 to 3 millimeters thick. Estrogen also stimulates endometrial cells to produce progesterone receptors, priming them for the progesterone-dominated secretory phase. The secretory phase involves the endometrium thickening as a result of secretion and fluid accumulation from day 15 to day 26. In response to progesterone, endometrial glands secrete glycogen. Glands grow wider, longer, and more coiled. By the end of this phase, the endometrium is 5 to 6 millimeters thick. Premenstrual phase, a period of endometrial degeneration during the last 2 days of the cycle. The corpus luteum atrophies and progesterone levels start to fall. It triggers spasmodic contractions of the spiral arteries, causes endometrium ischemia or interrupted blood flow, so the premenstrual phase is also called the ischemic phase. Lack of blood flow brings about death of the functional layer. Arterial spasms in the myocardium cause menstrual cramps. Pools of blood accumulate in the functional layer. Necrotic endometrium mixes with blood, and serous fluid forms the menstrual fluid. The menstrual phase, or menses, is a period where menstrual fluid is discharged from the vagina. First day of discharge is day 1 of the new cycle. An average woman expels about 40 mils of blood and 35 mils of serous fluid over a 5-day period. Contains fibrinolysin, so it does not clot. So, first day of discharge is day 1 of the new cycle. If you've ever experienced a pregnancy or known anyone that's gone through a pregnancy, typically they say 40 weeks is full term. If you do the math, 40 weeks, and you say, well, there's about 4 weeks in a month, so you're actually pregnant for 10 months. That's not true. So, they count you being pregnant from before you're even pregnant. Day 1 of your cycle is day 1 of that's the first day of your last period. So during the first 14 days of your quote-unquote pregnancy, you're preparing for pregnancy, but they count that as part of your gestational period. Sounds kind of weird. I don't really understand why they do it. I think day 1 should start on the day you ovulate, but because it's so difficult to determine the exact day of ovulation, and it's not really difficult to determine when did you start having your period, I think because the period is more of an outward sign, we can then more easily say, okay, day 1 of the period really starts the new cycle, and then you factor all of that in. So you truly are pregnant for 9 months. It's just they go back to day 1 of your period when they start to calculate gestational ranges. So here we go through the diagram of the cycle. So the menstrual phase, menstrual fluid is lost and the thickness of the endometrium declines. Then you have the proliferative phase where you start to increase the estradiol or estrogen, and a little bit of the progesterone levels start to increase. But once estrogen kind of levels off, then you have progesterone take over. At this point, we're going from, if we go back to this diagram here really quick, there we go. We're going from the follicular phase to the luteal phase. That kind of coincides with this diagram here. So here on the ovary, the follicle was developing, and then we had this ovulation event. And during the ovulation event, now we're going to start producing progesterone. That corpus luteum starts to produce progesterone to ensure that this endometrium lining is super thick and ready to accept an egg. It wants the woman to get pregnant at this point. So then we go into the secretory phase. Progesterone is largely involved here. So we will build up that uterine lining and get it ready for an implantation of an embryo. If that implantation doesn't happen, eventually the corpus luteum gives up, deteriorates, goes away, which means progesterone levels drop dramatically. And as soon as they drop, you're going to have the premenstrual phase and eventually menstruation. And here's the changing of that uterine lining throughout that. So that's what happens every month under a normal cycle. Now, what happens when you get pregnant? So we'll talk about the journey of the sperm. So the sperm, longer journey and unsuccessful for most. Only 20 to 200 million sperm out of 200 million per ejaculate get anywhere near the egg. The first challenge, this slide is not accurate. It should be 20 to 200,000 sperm out of 200 million get anywhere near the egg. The first challenge is to pass through the cervical canal into the uterus. The narrow folds and sticky mucus prevent it from getting through. The mucus does reorganize near the time of ovulation to allow for easier passage of sperm. inside of the uterus should be a sterile environment. The intent is to grow a baby in there, so we don't want to have a lot of nasty microorganisms. Now, unfortunately, the vagina contains all sorts of different organisms. And I don't mean that to be crass or gross, but there are hundreds of different types of species altogether that are growing inside of the vagina. And depending on whether the vagina has any diseases or, sexually transmitted infections or anything like that, there could be a lot more going on inside there. But basically, it's a warm cavity of bacteria, and bacteria love being inside of there. But we don't want that bacteria from colonizing the vagina to get up into the uterus. So we have this thick layer of mucus that typically coats over the cervix to prevent that bacteria from getting in there. Around the time of ovulation, though, we do want sperm to be able to get through. So the mucus reorganizes to allow for the passage of sperm. Less than 1% of sperm enter the uterus. Sperm move up the uterine mucosa. Even dead sperm can move up because the cilia inside of the fallopian tubes are constantly moving them up. And the contraction of the uterine wall. Uterine contractions are increased by oxytocin released during intercourse. Only a few thousand sperm make it to the openings of the uterine tubes, and half go up the wrong tube. Remember, typically we only ovulate from one follicle. From one follicle out of the 2 ovaries. So about half of the sperm will go all the way up the wrong fallopian tube when they really needed to go up the other fallopian tube toward the ovulation event. Freshly ejaculated sperm are not ready to fertilize an egg. They first need to undergo capacitation. They make the sperm membrane more permeable to calcium and activate receptors for chemical attractants. Fertilization occurs at the junction between the isthmus and ampulla of the uterine tube. At close range, sperm find the egg by chemotaxis, chemical attraction. They're attracted to progesterone from the cumulus ovorus surrounding the egg. As the sperm works its way through cumulus cells, calcium from the surrounding fluid stimulates the sperm tail lashing. When the head reaches the zona pellucida, it binds to the surface protein ZP3, triggering acrosome reaction, exocytosis of the sperm's acrosome. The sperm then reaches the narrow space between the ZP and the egg membrane, lies sideways as it binds. The sperm and egg membranes fuse, the sperm nucleus mid-piece, and most of the tail sink into the egg cytoplasm. Sperm mitochondria is not passed to the offspring because they're tagged with ubiquitin, marking them for later destruction by the egg. Prevention of polyspermy, the penetration by multiple sperm. So when one sperm enters, we don't want more sperm to also enter. So there's a fast block and a slow block that happen. The fast block, the egg membrane depolarizes when first penetrated, inhibiting attachment by another sperm. Slow block, the cortical granules release contents via exocytosis. Enzyme destroys ZP3 protein of the zona pellucida, blocking attachment of another sperm. So this shows those events. So penetration, the acrosome reaction, sperm-egg membrane fusion, the release of the sperm nucleus, and cortical reaction, and the reaction of or rejection of additional sperm. The secondary oocyte begins meiosis II before ovulation, but completes it only if it's fertilized. Through the formation of the second polar body, the egg discards one chromatin from each of its chromosome. Upon fertilization, sperm and egg nuclei swell and become pronuclei. Each pronucleus ruptures, and the chromosome of the 2 gametes mix in a single diploid set by the sperm centrosome. The fertilized egg, now called a zygote, is ready for its first mitotic division. So the fertilization event has to happen within the first third of the fallopian tube. If the fertilization event happens too late, what could happen is you may have a low implantation, or you may lose the fertilized egg. Now, losing of a fertilized egg is pretty common. It's just shed in the menses, and we typically wouldn't consider that an actual miscarriage. Levels of HCG usually don't increase to the point of being detected by a pregnancy test. Some physicians do call it a miscarriage, though, so it's scientifically, it was lost, but it was a fertilization event, so some people call it a miscarriage, some people don't. If a fertilization event happens too early, let's say it happens here, there's a big chance that this fertilization could then cause an implantation event to happen in the tube. And if the implantation happens in the tube, it's called an ectopic pregnancy, which we'll get into. I believe these slides go through ectopic pregnancy. We'll talk a little bit more about that. But if it gets fertilized too soon, then it could develop into a ball of cells that is too heavy to make its way down into the uterus and actually implant in the tube. Tubal pregnancies are the most common type of ectopic pregnancy. Another type of ectopic pregnancy is if the fertilization event happens really soon, then the developing embryo could implant in the abdominal cavity. So that's something that would not be able to be sustained. The course of pregnancy is divided into 3-month intervals called trimesters. The first trimester extends from fertilization through 12 weeks. More than half of all embryos die in the first trimester due to chromosomal defects. Conceptus is most vulnerable to stress, drugs, and nutritional deficiencies during this time. So if you're not trying to get pregnant, you accidentally get pregnant, you're still consuming a lot of alcohol during this time, you don't know you're pregnant, this is when we have a lot of those significant damages to the fetus is during this trimester. This is the most critical trimester for development of all the organs, so any type of medications, drugs, toxins, anything like that that's exposed to or that the fetus is exposed to have some detrimental effects. They say like a quarter of all pregnancies are lost during this trimester. Here it says more than half of embryos die in the first trimester due to chromosomal defects. It's typically considered a miscarriage if the baby is lost up until week 12. After week 12, they say at that point, most of the issues should have been detected by then, and you should know at that point. So usually 12 weeks is a relatively safe time that if there's a strong heartbeat and everything seems to be going well, then you have a much higher likelihood of having a normal, healthy pregnancy, and it's safe to start telling family and friends that you are expecting. Second trimester, weeks 13 to 24, organs complete most of their development. The fetus looks distinctly human, and the chance of survival with intensive care if born near the end of this trimester are there. There is a chance of survival. Third trimester, week 25 to birth, the fetus grows rapidly, organs achieved enough cellular differentiation to support life outside of the womb. At 35 weeks and 5.5 pounds, the fetus is considered mature. From a more biological standpoint, human development is divided into the preembryonic, embryonic, and fetal stages. So twins, dizygotic versus monozygotic twins. Dizygotic, about 2/3 of twins. 2 eggs are ovulated and both are fertilized by separate sperm, forming 2 zygotes, no more or less genetically similar than any other siblings. Implant separately in the uterine wall and each forms its own placenta. Monozygotic twins, 1 egg is fertilized, 1 zygote, but the embryoblast divides into 2 up to 14 days after fertilization. They are of the same sex and very similar in appearance, but they're not quite genetically identical. There are some genetic differences that occur due to mutations during gestation and DNA methylation that can cause differences in gene expression. So this shows dizygotic twins with 2 separate placentas. Implantation, it's the process of attachment to the uterine wall. Usually takes 1 week and occurs on the fundus or posterior wall. The process begins with when the blastocyst adheres to the endometrium. A trophoblast on attachment side separates into two layers. The superficial layer is in contact with the endometrium, plasma membranes break down, and the trophoblastic cells fuse into a multinucleate mass called the syncytiotrophoblaст. Deep layer close to the embryoblast, the cytotrophoblast, retains individual cells divided by membranes. Syncytiotrophoblasts grows into the uterus like roots, digesting endometrial cells along the way. The endometrium reacts to this by growing over the blastocyst and covering it. The trophoblast also secretes human chorionic gonadotropin. HCG stimulates that corpus luteum to secrete estrogen and progesterone. Progesterone stops menstruation. HCG levels rise in a mother's blood until the end of the second month. The trophoblast develops into a membrane called the chorion and takes over the role of the corpus luteum, making HCG unnecessary. Ovaries become inactive for the remainder of the pregnancy. Estrogen and progesterone levels rise from the chorion. So this is a diagram of that process happening, the implantation event. So it will stick, it forms roots, and then it gets encapsulated. So as I mentioned, ectopic pregnancy, the blastocyst implants somewhere other than the uterus. Most of them are tubal pregnancies. The tube will rupture within 12 weeks. Surgical removal of the embryo is necessary to allow the survival of the mother. There's no way to just move the embryo down into the uterus because it would require an entire implantation event, which has been stopped due to the hormonal regulation to promote the pregnancy. So that event can't happen after the fact. Less common is an abdominal pregnancy, as I mentioned. When the implantation occurs in the abdominal pelvic cavity, it can threaten the mother's life. 9% results in live birth by cesarean section. And these are just some diagrams of the developing human at the various stages. So 3 weeks, 4 weeks, 7 weeks. Typically at 6 weeks they have a heartbeat. 8 weeks, 12, 20. Embryonic membranes. The accessory organs develop with the embryo, placenta, umbilical cord, and 4 embryonic membranes: the amnion, yolk sac, allantois, and chorion. Embryonic membrane, starting with the amnion, it's a transparent sac that develops from the epiblast. It grows to completely enclose the embryo. It's penetrated only by the umbilical cord, and that fills with amniotic fluid. This is that clear sac. It looks like a plastic bag around the baby. The functions of the fluid: it protects the embryo from trauma, infections, temperature fluctuations. It allows freedom of movement, and it's important to muscle development. It enables symmetrical development. It prevents the body parts from adhering to each other, stimulates lung development as the fetus breathes the fluid. The yolk sac arises from hypoblast cells opposite the amnion, small sac suspended from the ventral side of the embryo, and contributes to the formation of the GI tract blood cells and future egg or sperm cells. Allantois begins as an outpocketing of the yolk sac. It forms the foundation for the umbilical cord and becomes part of the urinary bladder. The chorion is the outermost membrane enclosing all the rest of the membranes in the embryo. Has a shaggy outgrowths called chorionic villi around the entire surface. As the pregnancy advances, the villi of the placental region grow and branch while the rest of them degenerate. The smooth chorion. The villus chorion at the placental attachment forms the fetal position of the fetal portion of the placenta. So this shows that diagram of all of those different layers surrounding the baby. And that's a picture of the placenta. By the end of the 8 weeks, all organ systems are present. Individual is about 3 centimeters long and now considered a fetus. Bones have begun to calcify. Skeletal muscles exhibit spontaneous contractions. Heart's been beating since week 4. Now circulates blood. So week 6 of gestation, week 4 of the fertilization event. Heart and liver are very large, forming prominent ventral bulge. The head is nearly half of the total body length. Blood leaving the left ventricle, fetal circulation, it says continued, but I'm not seeing the previous slides, so we're just going to continue past this. I think some slides were removed. So gestation, pregnancy lasts an average of 266 days from conception to childbirth. Gestational calendar is measured from the first day of the woman's last menstrual period. Birth is predicted 280 days or 40 weeks from the last menstrual period. The duration of pregnancy, its term, is commonly described in 3-month intervals, as I mentioned, those trimesters. Conceptus refers to all products of conception, including the embryo or fetus, placenta, and associated membranes. Developing individual and associated structures, the blastocyst, the developing individual, is a hollow ball for the first 2 weeks. Embryo is from day 16 to week 8, and then fetus begins the beginning of week 9 to birth. A neonate would be newborn up to 6 weeks. So the hormones of pregnancy. Hormones with the strongest influence on pregnancy: estrogens and progesterone, human chorionic gonadotropin, human chorionic somatomammatropin. All primarily secreted by the placenta. Corpus luteum is an important source for the first several weeks. If the corpus luteum is removed before 7 weeks, pregnancy terminates. From week 7 to 17, the corpus luteum degenerates and the placenta takes over its endocrine function. Human chorionic gonadotropin is secreted by the blastocyst and the placenta. It's detectable in urine 8 to 9 days after conception by home pregnancy tests. Stimulates the corpus luteum. It doubles in size and secretes increasing amounts of progesterone and estrogen. Estrogen secretion increases 30 times normal by the end of gestation. The corpus luteum is the source for the first 12 weeks until the placenta takes over. Androgens from adrenal glands of mother and fetus are converted to estrogens by the placenta. Causes tissue growth in the fetus and mother. The mother's uterus and external genitalia enlarge. Mammary ducts grow, breasts increase to nearly twice their normal size, and relaxes the pubic symphysis and widens the pelvis. Progesterone, secreted by the placenta and corpus luteum. It suppresses the secretion of follicle-stimulating hormone and luteinizing hormone, which prevents follicular development. We don't want another follicle to develop if we're pregnant. Suppresses uterine contractions, prevents premature childbirth, and prevents menstruation. Promotes the proliferation of decidual cells of the endometrium on which the blastocyst feeds. Stimulates development of acini in the breast. Human chorionic somatomammatropin is secreted in amounts several times that of other hormones combined. Function is not well understood. The placenta begins secreting HCS around the 5th week and increases steadily until term. The effects are similar to growth hormone but weaker. It may reduce the mother's insulin sensitivity and glucose usage, leaving more for the fetus. Other hormones: the pituitary gland enlarges and produces markedly elevated levels of thyrotropin, prolactin, and ACTH. Elevated thyroid hormone increases metabolic rate of the mother and fetus. Parathyroid glands enlarge and increase osteoclast activity. Elevated ACTH stimulates glucocorticoid secretion, mobilizing amino acids for the fetal protein synthesis. Aldosterone secretion rises, promoting fluid retention, and increases the mother's blood volume. Relaxin, secreted by the corpus luteum and placenta, synergizes progesterone in stimulating multiplication of decidual cells, promotes the growth of blood vessels in the pregnant uterus, and inhibits premature uterine contractions. And here you can see a diagram of the weeks of gestation and levels of the various hormones. Adjustments to pregnancy. So the digestive system, nutrition and metabolism, morning sickness, nausea, especially arising from bed in the first few months of gestation. Constipation and heartburn due to reduced intestinal motility. We slow down the digestive tract so you can absorb more nutrients, so the baby gets more nutrients from what you eat. So that causes decreased motility, which causes increased constipation and heartburn. The pressure on the stomach also causes the reflux of gastric contents into the esophagus. So these are very significant for some women symptoms of being pregnant, and sometimes they don't tell you about all these side effects of being pregnant. Basal metabolic rate rises about 15% in the second half of gestation. Appetite may be stimulated. Healthy average weight gain is 24 pounds, depending. And I typically tell this story every time I talk about how much weight you should gain during pregnancy. During my first pregnancy, it was a normal, healthy pregnancy. However, I gained probably 70 some pounds during that pregnancy. I was already pretty overweight, and I ended up gaining a ton of weight during that pregnancy. And it was perfect. My baby was healthy. There was no risk of gestational diabetes. All of my blood levels, my urine levels, everything was great, and everything went well. During my second pregnancy, I was like, okay, I kind of went a little out of control with my first pregnancy. I'm going to actually exercise, and I'm going to eat healthy, and I'm going to be conscious of how much I weigh, and I'm going to monitor things to make sure that I'm gaining a healthy amount of weight. So in my mind, I was doing the right thing during my second pregnancy. I had a ton of complications during my second pregnancy, which I won't get into, but almost ended up dying during my second pregnancy. So it was a lot of complications, a lot of things that went wrong that, maybe it was diet related. Probably some of it was, but yeah. You gain how much you gain, and you enjoy life. As long as you're not gaining to the point where it's putting the baby at risk, then you're completely fine to gain what your body decides it needs to gain during the pregnancy. Digestive system, nutrition, and metabolism continued, so the placenta stores nutrients in early gestation and releases them in the last trimester. Vitamin K is given in late pregnancy and newborns to promote prothrombin synthesis, minimizes the risk of neonatal hemorrhage, especially in the brain. Vitamin D supplements ensure adequate calcium absorption to meet the fetal demand, and folic acid reduces the risk of folic acid reduces the risk of neurological fetal disorders, spina bifida, anencephaly. Supplements must be started before pregnancy. So folic acid is an essential vitamin that needs to be taken during pregnancy. This is why prenatal vitamins are strongly recommended. The circulatory system, the mother's blood volume rises about 30% during pregnancy. Due to fluid retention and hemopoiesis, the mother has about 1 to 2 liters of extra blood. Mother's cardiac output rises. Pregnant uterus puts pressure on larger pelvic blood vessels and interferes with venous return from the legs. So sometimes you can get hemorrhoids, varicose veins, edema in the lower extremities and feet. The respiratory system, the tidal volume and minute ventilation increase about 40% though the respiratory rate remains constant. Reasons for increased ventilation: more oxygen demand. Fetal hemoglobin has a much higher affinity for oxygen than the mother's hemoglobin, than adult hemoglobin. And it should, because the baby needs to get its own oxygen too. The baby's growing and needs its own ATP and all that kind of stuff. So we need to bring more oxygen into the body so that the baby can have some of that oxygen as well. Urinary system, aldosterone and steroids of pregnancy promote water and salt retention by the kidneys. Glomerular filtration rate increases by 50% and urine output is slightly elevated. The pregnant uterus compresses the bladder and reduces its capacity. So pregnant women typically have to pee every 5 minutes, especially toward the end of their pregnancy. Frequency of urination increases and uncontrollable leakage of urine can happen. Skin. So skin growth accommodates expansion of the abdomen and the breasts, added fat deposit in the hips and thighs. The striae or stretch marks can result from tearing the stretched connective tissue. Reddish at first but fade after pregnancy for the most part. Melanocyte activity increases in some areas, darkening of the areola. Temporary blotchy darkening of skin on the nose and cheeks. Uterine growth and weight gain. So the uterus weighs about 900 grams at the end of pregnancy. It weighs only 50 grams when you're not pregnant. So reaches almost to the xiphoid process. Childbirth. In the 7th month of gestation, the fetus normally turns its head upside down. Most babies born head first. The head is acting as a wedge that widens the mother's cervix, vagina, and vulva during birth. The fetus is a passive player in its own birth. Expulsion is achieved by contractions of the mother's uterine and abdominal muscles. The fetus must play a role chemically by stimulating labor contractions, sending chemical messages that signify when it's developed enough to be born. So this is when the baby flips and is head down. Braxton Hicks contractions are relatively weak contractions of the uterus over the course of gestation. During true labor at term, the contractions are the most powerful labor contractions. True labor contractions signal the start of parturition, the process of giving birth. Progesterone and estradiol balance may be one factor in this pattern of increasing contractility. As the pregnancy nears full term, the posterior pituitary releases more and more oxytocin, and the uterus produces more oxytocin receptors. Oxytocin promotes labor in two ways: directly stimulates muscles of the myometrium and stimulates fetal membranes to produce prostaglandins, which are synergists of oxytocin in producing labor contractions. Conceptus may produce chemical stimuli promoting its own birth. Fetal cortisol rises and may increase estrogen secretion by the placenta. Fetal pituitary produces oxytocin, which may stimulate fetal membranes to produce prostaglandin. Uterine stretching through the thought to play a role in initiating labor. Labor contractions begin about 30 minutes apart, eventually every 1 to 3 minutes. Contractions are the strongest in the fundus and body of the uterus. Weakest in the cervix, pushes the fetus downward. Positive feedback theory of labor. Labor induced by the stretching of the cervix triggers a reflex contraction of the uterine body, pushes the fetus downward, stretches the cervix even more, self-amplifying cycle of stretch and contraction. Cervical stretching induces a neuroendocrine reflex through the spinal cord, which causes more oxytocin. So more oxytocin, more contraction, more pushing, more stimulating the cervix. And it kind of continues in that positive feedback cycle until labor happens. At first, the pain of labor is mainly due to ischemia of the myometrium, but as the fetus enters the vagina, the pain becomes stronger, the stretching of the cervix, vagina, perineum, sometimes with tearing. Episiotomy may be necessary, and that's an incision in the vulva to widen the vaginal orifice to prevent random tearing. Pain is an evolutionary product of two factors: large brain and head of the human infant and narrowing of the pelvic outlet, which helped humans adapt to bipedal locomotion. 3 stages, so dilation, expulsion, and placental delivery. The duration of each stage tends to be longer in a primipara, a woman giving birth for the first time, and shorter in a multipara, a woman who has previously given birth. So dilation, the first stage, this is the longest. It lasts 8 to 24 hours. The cervical canal has to reach 10 centimeters, and effacement or thinning of the cervix has to happen. The rupture of the fetal membranes and loss of the amniotic fluid, or their water breaking, is a part of this. Expulsion occurs from the entry of the head into the vagina until the baby is expelled, 30 to 60 minutes. Crowning, the baby's head becomes visible, and the delivery of the head is the hardest part. So this shows those stages. Expulsion, and then placental stage, that is when you expel the placenta from the uterus. So uterine contractions cause placental separation. Membranes or afterbirth is inspected to be sure everything has been expelled. If part of the placenta is retained inside of the uterus, it can become infected and can be life-threatening to the mother. So they literally run through the placenta and make sure that all of it's there. I used to deliver cows on a dairy farm. We did the same thing there. We would run the placenta to make sure there's no pieces that look like it was missing, to make sure that the cow wasn't then going to go on and have an infection afterwards. The first 6 weeks postpartum after birth are called the puerperium. It's a period when the mother's anatomy and physiology stabilize and reproductive organs return nearly to their condition before pregnancy. Involution, the shrinking of the uterus, loses 50% of its weight in the first week. Involution is achieved by autolysis, self-digestion of uterine cells by their own lysosomal enzymes. For about 10 days, it produces vaginal discharge called lochia, bloody at first and then turns serous. Breastfeeding also promotes involution of the uterus. Lactation, the synthesis and injection of milk from mammary glands, it lasts as little as 1 week in women who do not breastfeed their infants. Can continue for many years as long as the breast is stimulated by a nursing infant or a mechanical device like a breast pump. Women traditionally nurse their infants until a median age of about 2.8 years. Although they say 6 months of breastfeeding is good, some women cannot produce breast milk. Either their baby didn't latch on right away. There's not the saliva exchange from latching on from the baby's saliva, latching onto the nipple that stimulates milk letdown process. Maybe the baby was born prematurely. Maybe the mother has health issues going on. So for various reasons, sometimes it's not possible for a mother to continue to breastfeed at all, or to continue to breastfeed more than just several months. Several hormones in pregnancy stimulate the development of mammary glands. So high estrogen causes the ducts of the mammary glands to grow and branch. Growth hormone, insulin, glucocorticoids, and prolactin contribute to this development. Progesterone stimulates the budding and development of acini at the end of ducts. Colostrum, the secretion is similar to breast milk in protein and lactose, but contains 1/3 less fat. It forms late in pregnancy, and it's the sole nutrient source for the first 1 to 3 days after birth. Thin, watery consistency and a cloudy yellow color. It contains IgA to protect the baby from gastroenteritis, or bacterial infections of the GI tract. Prolactin promotes milk synthesis. It's secreted by the anterior pituitary gland, inhibited by dopamine, prolactin inhibiting hormone, when not pregnant. Synthesis of hormone begins 5 weeks into pregnancy. By full term, it's about 10 to 20 times the normal level. Milk synthesis also requires a bunch of other hormones, and those are necessary to mobilize all of the nutrients that go into the milk. Prolactin surges occur every time an infant nurses. At birth, prolactin secretion drops to non-pregnancy levels. Every time the infant nurses, prolactin levels jump 10 to 20 times this level for an hour. 5 to 10% of women become pregnant while breastfeeding. So this shows prolactin surges during breastfeeding. Milk ejection, also known as milk letdown, is controlled by a neuroendocrine reflex. Milk is constantly secreted into mammary acini, but does not easily flow into the ducts. Infant suckling stimulates sensory receptors in the nipple, signaling the hypothalamus and posterior pituitary to release oxytocin. Oxytocin stimulates myoepithelial cells around each acinus, contract to squeeze the milk into the duct. Differences in composition of colostrum, human milk, and cow's milk are significant. Colostrum and milk have a laxative effect that clears the intestine of meconium, the green bile-filled fecal material in the newborn. Breast milk supplies antibodies, colonizes the intestine with beneficial bacteria. Cow's milk is not a good substitute. It has 1/3 less lactose, but 3 times as much more protein. It's harder to digest, which means that the baby's going to have more nitrogenous waste, which leads to diaper rash. It also doesn't stimulate the digestive tract to eliminate that bile. So bile can start to accumulate inside of the baby, and that can be fatal or can cause lifelong neural defects. Breast milk changes composition. It changes over the first 2 weeks, varies from one time of the day to another, and throughout a single feeding. So the neonate, the transitional period, the first 6 to 8 hours immediately following birth, when the neonate must adapt to life outside the mother. Heart and respiratory rates increase, body temperature falls, physical activity declines, and the baby sleeps for about 3 hours. During the second period of activity, the baby often gags on mucus and debris in the pharynx. The baby sleeps again and becomes more stable. and begins cycle of waking every 3 to 4 hours to feed. Neonatal period, the first 4 weeks of life. Infant at this stage is called a neonate. They have adapted to life on the outside. They've had begun breathing. They've made great effort to inflate the lungs. Circulatory adaptations occur. So umbilical arteries start to deteriorate because they no longer need the umbilical cord in order to get nutrients from the mother. Immunological adaptation, cellular immunity appears in fetal development, but it's still weak. An infant is born with near adult levels of IgG from the mother through the placenta. Maternal IgG breaks down rapidly after birth, but it remains high enough for 6 months to protect against measles, diphtheria, polio, and most other infectious diseases. A breastfed neonate acquires protection from gastroenteritis from the IgA present in colostrum. Other adaptations, thermal regulation, so they're able to regulate their body temperature better. Fluid balance, their kidneys are in full function. Premature infants are infants that are born before week 37. Multiple difficulties in respiration, thermal regulation, excretion, digestion, and liver function. At 37 weeks, the average baby is 5.8 pounds. Infants born before the 7 months have a deficiency of pulmonary surfactant, resulting in infant respiratory distress syndrome. Alveolar can collapse with exhalation, and it takes great effort to reinflate them. It's treated by ventilating the lungs with air at positive pressure and the administration of surfactant. Thermoregulatory problems are due to undeveloped hypothalamus. So babies that are premature need to be put in an incubator with supportive care. There's digestive issues, an immature liver, and things that must be monitored and regulated. So they aren't allowed to leave the hospital because of the extensive amount of monitoring that's required. Birth defects. So birth defects are congenital anomalies, abnormal structures or positions of organs at birth resulting from a defect in the prenatal development. Teratology is the study of birth defects. Not all are noticeable at birth. Some are detected months or years later. In 50 to 60% of cases, the cause is unknown. Teratogens are agents that cause anatomical deformities in the fetus. They fall into 3 major classes: drugs and chemicals, infectious diseases, and radiation. Teratogen exposure during the first 2 weeks may cause spontaneous abortion. Period of greatest vulnerability is weeks 3 through 8. Teratogens like thalidomide taken by mothers for morning sickness or insomnia cause babies to be born with unformed arms and legs, and often with defects of ears, heart, and intestine. It's taken off the market in 1961, but can be used in controlled conditions to treat leprosy. Alcohol causes more birth defects than any other drug. Fetal alcohol syndrome, characterized by a small head, malformed facial features, cardiac and central nervous system defects, stunted growth, and behavioral signs such as hyperactivity, nervousness, and poor attention span. Cigarette smoke, diagnostic x-rays, several microorganisms can cross the placenta and cause serious anomalies, stillbirth, and neonatal death. Viruses include herpes, rubella, cytomegalovirus, and HIV. Bacterial infections, gonorrhea, and syphilis can produce blindness, hydrocephalus, cerebral palsy, seizures, profound physical and mental retardation. Cleft lip and palate, failure of the fetal maxillae to join the midline, leaving a median fissure in the roof of the mouth, often accompanied by the lower lip cleft, one of the most common congenital malformations. Mutations and genetic anomalies. Genetic anomalies account for 1/3 of all birth defects. Mutations are the changes in DNA structure. Example conditions resulting from mutation: achondroplastic dwarfism, cleft lip and palate, microcephaly, stillbirth, and childhood cancer. Mutagens are environmental agents that cause mutation. Some genetic disorders result from non-disjunction or failure of the homologous chromosomes to separate in meiosis. So typically we would have the chromosomes split apart. If they don't split apart, so you've got two copies of the chromosome. If both of these copies happen to go to one cell, then this cell is missing. And if it's used as a zygote, then it would be, or used as a gamete to produce a zygote, then that zygote would be missing a copy. Now, if this one was used as a gamete, this zygote would have 3 copies. So aneuploidy is the presence of an extra chromosome or the lack of a chromosome. Most common cause of miscarriage. Monosomy, the lack of a chromosome, leaves one without a match. So monosomy, you only have 1 copy of a chromosome. Trisomy, you have an extra copy. So you have 3 copies of a particular chromosome. Under normal conditions, we should only have 2 copies of every chromosome. 1 copy comes from the sperm, 1 copy comes from the egg. But monosomy, we're missing 1. Trisomy, we have 1 extra, so we have 3 copies. Select monosomies and trisomies don't cause miscarriage. Select monosomies and trisomies can go on to survive, but there are defects in the surviving babies. Aneuploidy can be detected prior to birth by amniocentesis or chronic villi sampling. Both of those processes have risks to the unborn baby. So non-disjunction of the sex chromosomes can also occur. As I mentioned, the triple X syndrome, the egg receiving 2 X chromosomes are fertilized by the X-carrying sperm. Some are infertile females and have mild intellectual impairment or both. Klinefelter syndrome, XXY, sterile males of average intelligence but with undeveloped testes, sparse body hair, unusually long arms and legs, and enlarged breasts. Turner syndrome or XO syndrome, the egg contains no X chromosome but is fertilized by X-carrying sperm. About 97% die before birth. Survivors show no serious impairment as children, but webbed necks, widely spaced nipples, secondary sex characteristics failed to develop at puberty, and the girl remains sterile, usually short in stature. Only 3 autosomal trisomies are survivable, and they involve chromosomes 13, 18, and 21. 13 is Patau syndrome. 18 is Edwards syndrome. Nearly all die before birth. Some live for more than a year, but typically exhibit seizures and severe mental disability. Down syndrome is trisomy 21, so the 21st chromosome has 3 copies. It's the most survivable trisomy. Impaired physical development, short stature, relatively flat face with flat nasal bridge, low set ears, epicanthal folds at medial corners of the eye, enlarged protruding tongue, stubby fingers, short, broad hand with 1 palmar crease. Outgoing, affectionate personalities, mental retardation is common. About 75% die before birth. 20% of those born die before age 10. Survivors beyond age 10 have a life expectancy of 60 years. The chance of having Down syndrome as a child is 1 in 3,000 in a woman under 30, 1 in 365 by age 35, and 1 in 9 by age 48. Aging eggs have less and less ability to separate their chromosomes, so the longer the egg sits on the ovary, the more likely we are to have this develop.